All right, so I'm going to introduce our first speaker. We have Dr. Soum Lokeshwar. He was born and raised in Miami, Florida, and he's in a 7-year combined med program and then MBA at University of Miami. He has an interest in academic urology. He's an avid brunch enthusiast, a member of fine arts, including history, and for the record, he wrote this himself, so I'm going to go ahead and report it. He has great respect for his chief residents, including his favorite trust.
So thank you and good morning. My name is Soum Lokeshwar. I'm an MD MBA here at Yale University, and I have the honor of presenting Pondering the Prostate from Discovery to the Cusp of the Modern Era. I have no disclosures yet. So I just want to talk to you briefly about what I'll be speaking about. First, we'll dive into the history and discovery of the actual prostate. Then we'll change speeds and go to the discovery of prostate cancer. After this, we'll talk about prostate cancer at its core, and we'll move on to PSA, and then I'll leave you with the current state of affairs in prostate cancer. So the prostate is as old as history itself. We begin in ancient Greece with the first suggestion of the prostate by Herophilus of Chalcedon. Through the vivisection of animals and criminals, this was live criminals who were caught, he was able to see that there may have been some sort of gland attached to the bladder. However, the first description came with Galen of Pergamum, who described the prostate as glands which poured a humor into the urinary passages of the male to excite the sexual act. Herophilus called these glands parastatae adenoides, or glandular assistants that assisted the male in reproduction. But the first suggestion of the prostate as an independent gland was not yet formed. This came with the Romans, with Aulus Cornelius Celsus in 45 AD, who described a surgery in which he said perineal lithotomy was best reserved for prepubescent boys. And I only wonder, is that because of the prostate in elderly men? And just as the birth of music, the birth of art, the birth of history during the Renaissance, there was also the birth of an organ. Niccolo Massa in the 1500s, in his Introduction to Anatomy, described the prostate as a glandular flesh upon which rests the neck of the bladder and extremities of the seminal vesicles. And then we had Andreas Vesalius, who blessed us with the first illustration of a prostate in 1537. This was on the fabric of the human body, in which he had eloquently described the prostate as the glandulous body into which the vessels that bring down semen insert after they come together, located at the bottom of the bladder and its neck. It is a single body, not exactly round, has a depression at the front and back, at the sides is perfectly spherical, just as we say to our patients, the walnut. And thus the prostate had become an organ. So here I want to turn your attention to the beautiful rendition of the Renaissance painting, which prompted the further discovery of the prostate. Here you can see a lovely heart-shaped gland just at the base of the bladder, as you can see here. And so for most of history, the prostate was simply a nuisance. Andrew de Lorens first called the prostate because of a mistranslation from the ancient Greeks, from Galen, who at first said it was prostatae instead of parastatae, the glands in front of the bladder. And for a greater part of the next few centuries, surgeons simply saw the prostate as an organ in the way during perineal lithotomies. These lithotomies were performed for bladder stones, for retention, for hematuria, things we all have known to come and love. Surgeons learned to cut through, around, and under, and into the prostate. And this is a lovely rendition of what it looked like back then, with assistants holding down the patient and a surgeon gleefully cutting into the perineum to get out a large bladder stone. And Jean Roland the Younger in the 1600s first published on the obstructive effects of the prostate, especially in the way of voiding and dilations of the urethra. As you can see here, these are some ancient drawings of the prostate mangled and covering the bladder, not allowing a patient to urinate. But it wasn't until Morgagni that the first book of pathological anatomy was published. Before this, anatomy was only demonstrated in its virgin state, without pathology. And he described the median lobe causing urinary retention. He perfectly put it as an excrescence of the prostate gland in the form of a pear, and scarcely leaving any passage, the fibers of the bladder resemble the strong bundles of the fiber in the heart. And the 1800s were marked with controversy of whether the gland was pathological due to enlargement, or was it an inevitable cause of old age? Or was it simply due to celibacy, where men who did not procreate, who did not ejaculate, had large obstructing prostates? And then we go from God's first creation to a vile perversion, prostate cancer. In 1817, Langstaff described prostate cancer as fungus hematodes, fungus-like growth protruding into the bladder with origin within the prostate, sprouting up as fungi would in your garden, with several lesions of similar appearance in the liver and lungs. From 1820 to 1850, after this discovery, there was only sporadic cases demonstrated of prostate cancer. It was considered a novelty. It was considered rare. In 1853, James Adams, a surgeon at the London Hospital, described a case of serous of the prostate gland with corresponding affliction of the lymphatic glands in the lumbar and region and pelvis. Thus, pathological prostate cancer, so microscopic prostate cancer, was created. In 1870, William Ferguson suggested removing the prostate to relieve urinary symptoms. Removal of the prostate by either pulled or cut out or enucleated using a surgeon's finger. And as you can see here, this is kind of how surgery was performed. It was performed blind due to bleeding, due to poor exposure of the prostate, and the prostate was simply cut through. It was never removed in its entirety. And so flirtations with the prostatectomy began with Otto Zuckerantal, who performed the first elective extra-urethral prostatectomy. This wasn't removing the entire glands, but simply part of the gland to relieve urinary obstruction. It wasn't until George Goodfellow, who was an American, who was more cowboy than surgeon, more cowboy than doctor, who was famous for gunshots in Arizona, who performed the total perineal finger enucleation of the prostate almost at the turn of the century. This was simply getting into the right plane and then scooping out the prostate with a finger, never minding the urethra, never minding erectile dysfunction. He performed this entirely by feel, given the amount of blood and other tissue in the way. And he reported in a case series of 72 patients, only 2 deaths. However, there was no mention of after-surgical deaths, and there was no mention of morbidity. And unfortunately, the first one he did in 1890 was before he founded spinal anesthesia. Arthur Ferguson McGill also talked about first prostate enucleation through the open bladder in 1887. And he actually presented his work, just as I'm presenting my work here, in 1889, with a row of patients sitting with jars containing their prostates at their feet. And so now we move into the 1900s, when the prostatectomy was a new tool that surgeons could offer. And of course, they wanted to use it. Sir Peter Fryer in 1912 performed 1,000 suprapubic prostate enucleations. And as you can see here, we've come a long way. Here, a surgeon is using his hands to grip and rip out the prostate. It was a very rough surgery. It wasn't the delicacy which we have now. And it wasn't until the birth of the radical prostatectomy with Hugh Campton Young that we moved into the modern era. For those who don't know, Hugh Campton Young is considered the father of modern urology. He started the first urology residency. He trained most of the giants we know and have come to love today. And he learned the perineal prostatectomy from Dr. Goodfellow. At the beginning of his career, he performed simple perineal prostatectomies for urinary obstruction. These prior techniques did not remove the entire organ. So this wasn't yet a cancer surgery. This was simply for obstruction. For a cancer surgery, you have to, as we know, remove the entire gland. But through his observations, through his brilliant inventions, including the prostatic retractor, in April 7, 1904, he performed the first radical prostatectomy, removing the entire prostate and surrounding tissue on an elderly preacher. He was able to perform this under vision rather than feel due to proper exposure and proper blood control. And during that year, for the rest of the year, he performed 4 4 more prostatectomies. And I want to just narrow you in. He was only 34 when he first performed this radical prostatectomy. So he had his entire career ahead of him. And he had a remarkable career. Here you can see he's truly in an operating room theater with 50 to 100 urologists or budding surgeons watching him as he operated. Oftentimes there was standing room only, and he had almost 5 assistants help him. And we moved on with refining the art with the retropubic prostatectomy with Terence Millen. In 1945, he performed the first retropubic prostatectomy. But Terence Millen was both performer as well as surgeon. During the Royal Society of Medicine meeting in 1945, Millen brought in his prostatectomy patient from a week prior, gave him multiple beers, and had him urinate directly on the floor to show that he had great flow from his patients. Although this surgery was successful, although mortality was now lower, there was reportedly all patients with erectile dysfunction, and 25% had florid incontinence. So because of these side effects of prostate cancer, there was the rise of alternate therapies. It had an arms race, if you will, just as the Soviets and the Americans had their arm race, prostate cancer had its own. And this came to radiation therapy, which was happening simultaneously. In 1913, there was the direct implantation of radium into the rectum and urethra for palliation. However, this wasn't as accurate as we had today. Oftentimes, all of the radiation would be given to the bladder, to the rectum, and to the urethra. And this was very morbid for patients. They would have multiple side effects. This would be done awake. In the 1940s to the 1960s, it was still done awake with radium-containing needles in the prostate gland itself via the perineum, and the rectum or the open bladder. It wasn't until the 1950s, which we have external beam radiation therapy with cobalt, which is still used today, EBRT. And in 1970s, Willett Whitmore described an open implant technique using radioisotope of iodine, sealed in miniature titanium cylinders and inserted into the prostate without the aid of any imaging device, simply by feel. Although this was well tolerated, as you can expect, these cylinders were placed blindly. So oftentimes part of the prostate would get radiation, other parts would not, and it wasn't very efficacious. This also led to androgen ablation therapy in the 1940s, with the famous quote from Huggin and Hodges, who did win a Nobel Prize, demonstrating that prostate cancer is influenced by androgenic activity in the body, at least with respect to serum phosphatases. Disseminated carcinoma of the prostate is inhibited by eliminating androgens through either castration with orchiectomy or through neutralization of their activity with estrogen injection. And this was huge. This is still the basis of how we treat prostate cancer with androgen deprivation therapy. However, as we know, as unfortunately, there's castration-resistant prostate cancer. There's patients who aren't amenable to having castration, just given all of the side effects. At this time, there was even more side effects than we have now. And so for the next 40 years, prostatectomy definitely languished. People did not offer it as much because patients were scared of it. They didn't want to lose their livelihood. And then came Dr. Patrick Walsh, who we had the pleasure of hearing just a few weeks ago. And along with Peter Donker, Dr. Walsh on February of 1981, dissected out the cavernous nerves in a stillborn male infant. He was the first one to do this. And you can imagine how small this was back then. And he was able to really dissect out those nerves. And in the next year, intraoperative observations identified the capsular arteries and veins of the prostate as a likely microscopic landmark that could be used in the adult male pelvis to identify the microscopic cavernous nerves. Putting all of this together, he entered the operating room on April 26, 1982, and performed the first purposeful nerve-sparing radical prostatectomy, putting prostatectomy back on the map. And he published 2 key principles for the nerve-sparing prostatectomy. The incision of the lateral pelvic fascia is placed anterior to the neurovascular bundle, located dorsolateral to the prostate along the pelvic side wall. The lateral pedicle is divided close to the prostate to avoid injury to the branches of the pelvic plexus that accompany the capsular vessels of the prostate. And truly, his publications were a work of art. As you can see here, he's demonstrated clearly where the neurovascular bundles were. He shows us a very in-depth view of these nerves and vasculature, how they intertwine. And he actually gives budding urologists kind of where to cut and where not to cut in bold letters here. And just along this time, the PSA, or prostatic-specific antigen, was discovered. In 1960, Phlox was the first to experiment with prostate antigens. In 1970, Adlin, who is considered the father of the PSA, reported the presence of precipitation antigens in the prostate. And actually, as a fun fact, for the past 20 years, Adlin has actually fought against the routine surveillance with PSA, almost like with the atomic bomb, they're voicing against it. In 1979, Wayne purified a tissue-specific antigen from the prostate. 1980, PSA was first measured quantitatively in the blood by Papsidero, and Stamey carried out the initial work on the clinical use of PSA as a marker for prostate cancer. Therefore, in 1986, FDA approved the PSA for monitoring patients with established PCA. And this is wild to me that 1986, before this, we didn't have PSA in our back pocket when patients came in. And so Dr. Catalona, who actually was present at the AUA in the New England Journal of Medicine in 1991, published the measurement of PSA in serum as a screening test for prostate cancer. He looked at the PSA concentrations of almost 1,700 men over the age of 50. Those with PSA values greater than 4 underwent DRE and prostate ultrasound. Ultrasound-directed prostatic needle biopsies were performed in men with abnormal findings on rectal examination, ultrasonography, or both. What he found is that in 6.5% of patients, or 107 patients, PSA ranged from about 4 to about 10. In those with greater than 10 PSA, it was about 1.8%. And sorry, this is a typo, but 22% who had prostate biopsies had prostate cancer. If rectal examination alone was used, 32% would have been missed. And ultrasound alone, 43% had been missed. So what they concluded was that serum PSA measurements had the lowest error rate of the test, and PSA measurements plus rectal examination had the lowest error rate of the two test combinations. And this really became our gold standard until the rise of other imaging such as MRI. Given this work, the FDA approved the screening of PSA in 1994. And putting this all together, Dr. Walsh published in 1999 in JAMA, The Natural History of Progression After PSA Elevation Following Radical Prostatectomy. Before this, prostatectomy was argued, is this really necessary for patients with prostate cancer? We knew that the effect was there, but it hadn't been clearly demonstrated as before this. So this was a retrospective review of almost 2,000 patients from 1982 to 1997. And it showed that over a median follow-up of 5 years, metastasis-free survival for all 2,000 men was 82%. At 15 years after surgery, of the 2,000 men, only 15% developed biochemical PSA elevation, only 15%. This truly sealed prostatectomy as one of the surgeries we do use and one of the main treatments for prostate cancer. And then we enter into the robotic age. In 2001 in European Urology, a very small case series of 5 patients in France was published using the robot. These were cherry-picked patients. They were 58 years old, healthy, PSA of 12, Gleason score of 6. The mean installation time they found for the robot was 93 minutes. I don't know if Dr. Kim in your OR, we do it faster than an hour and a half. The mean operating time for starting the dissection of seminal vessels until the final stitch was about 222 minutes. Average blood loss was very high, 800 cc's. However, there was no postoperative complications. Patients did stay in the hospital for 6 days. I think this was just because of an abundance of caution. But as you can see here, this was the first robotic console developed in 1996. It's not as glitzy as our Da Vinci Xi, but it certainly got the job done. And so now, what is the task at hand? In 2023, greater than 85% of radical prostatectomies are performed robotically. There's still about 300,000 new cases of prostate cancer, about 35,000 deaths from prostate cancer in the United States alone. This is in the United States with all of our modern medication. And so really we're left with certain questions, when to operate, when to use active surveillance, what treatment to give these patients. What is the true balance between radiation therapy, chemotherapy, medical therapy? And what is the true treatment for metastatic prostate cancer that's locally invasive? What is the treatment for castrate-resistant prostate cancer? In all of this history, I feel like we are somewhere in the middle of prostate discovery. I think there's a lot more that we need to accomplish, and I'm excited to one day start my career. Thank you.
This is excellent.
Thank you.
I learned a lot. Going off the last slide. So where do you think, in terms of debate about the balance, let's say, or where is that discussion going right now?
So it's interesting. I think kind of the real space is probably locally invasive metastatic prostate cancer. It could be wrong. There are those who feel like prostatectomy, active mothership is beneficial, which I agree as well. In our institution, but there's others who would completely ask for radiation, straight to chemotherapy. So I think it is a balance. I think it depends on who you ask. I think if you ask urologists, we'll definitely say prostatectomy is gold standard. However, that's for certain patients. That's for patients who can undergo surgery. So I think in my opinion, I think it should definitely be offered for patients who are medically fit. But I know that there's others. That's why we do share decision making. I think we kind of put on the patient as much as we put it on as providers.
I think one of the major issues is that surgery is so difficult to standardize, and that's why these debates are happening. Is that if you only concentrate on the top performance, then the outcomes are excellent, and you could take that with any of the treatments, and surgical outcomes are excellent. But that's not the case. I think the next, so I see it's not struggle, but our challenge is to how do you standardize operations? Still huge variations in terms of outcomes.
Do you find if you have patients who come in, I'm sure you get a lot of referrals for patients who are kind of shopping around looking for surgery versus radiation, and ultimately decide to undergo surgery and then have buyer's remorse after the fact. Is it one of those things that people are ultimately satisfied with the choice that they make, whatever that choice may be, or do you think we're doing a good job of selecting out good surgical candidates, or people who would be satisfied with it?
No, but I think it's more, so the patients that I've seen where they have the remorse are the ones who really focus on erectile dysfunctions. So throughout my career now, I stressed it really upfront that if there's anything that the surgery is not better than radiation, let's get some erectile dysfunction. So I try to counsel them up front as best as I can. Nevertheless, that has continued to happen, but the percent certainly is lower. Much more selective, not selective, but counsel the patients much better than early on in my career. So that certainly has changed. I think it's also the experience that you have in decreasing that the remorse or regret after surgery.
It seems like younger men would be more concerned about the erectile function.
Not necessarily. One of the most patient I had was like 82-year-old. Yeah. All right. But it did get better.
So it's like,
Oh, sorry.
Go ahead.
We have a great historical medical library here.
Mhm.
Have you had a chance to look for any primary resources?
I've looked at other stuff with them, but yeah, I definitely want to talk with them about this.
According to our website, we came down to young trained John Churchman, who came here for the first cystoscopy at Yale. So I'd be interested to know if there's any.
Yeah, I should reach out to them. They're always so friendly, so I'll definitely go. All right, thank you.
Thanks. It's great to have.
So
Good morning, everyone. My name is Ankur. I'm one of the 30-year residents as well. I'm going to change the title of my talk to one of my peers called Transcending Transplant, Urologic Requirements. So just a disclaimer, a lot of this talk is going to be related to kidney transplantation, just as that's where we have the most impact. But the concept of immunosuppression or any other type of organ that's being transplanted can carry over and be relevant as well. So just going over the main benefits of solid organ transplant, both improvement in morbidity, in quantity and quality of life, and especially for organs such as liver, heart, lung. These interventions can be life-saving. For patients that are transplanted with a kidney, the average increase in their survival is about 12.4 years. About 800,000 patients live in the US with ESRD, of which 80% are on dialysis. There's about 25,000 kidney transplants that we do, while about 90,000 patients remain on that wait list. And as of 2 days ago, there are 925 patients just in Connecticut themselves that are on the wait list for a kidney transplant. So you can see that there's an obvious mismatch between the resources, the availability of organs, and the recipients that require the transplant, creating a huge wait list of patients that we will see. The risk of death following the first year after transplantation is right around 5%. So it's really important to identify candidates that would be able to maximize the use of these organs. So this is one of the few fields of medicine where we are resource driven when we decide who to treat. And when we look at ESRD and urologic volumes for pediatric patients, about 20% of these patients have an underlying urologic issue that led them to go on to ESRD. And for adult patients, that's more about 5%. And as we continue to excel in our medical care of patients, the number of patients over the age of 65 increases by how much are being transplanted. That increased age also means that they're harboring more gene pathologies with their increased age. So the role of urologist, this is mainly the organs we treat, but when we're looking at a kidney transplant patient, we have an additional organ that we have to consider. And the urologic requirements for successful renal transplant are threefold. One, we want to ensure the absence of UTIs as well as urinary calculi. We want to exclude genital urinary malignancies, which might portend on their long-term prognosis. I'm going to implant this kidney into a functional lower urinary tract. If you have all three, we get the AUA certification to undergo a kidney transplant. And when we look at the lower urinary tract system, three essential features of this is it provides an adequate reservoir to allow the storage of urine at low pressures. It allows you competent urethral mechanisms to allow for urinary incontinence, and a easy and convenient way for urine to exit the bladder, either by volitionally or through catheterization. So the basic urologic evaluations for transplant patients can be very much similar to how we would evaluate any other patient that we're seeing, detailed H&P, as well as understanding the amount of urine that they're making from their native kidneys before they're going to a transplant, because that's going to help understand their post-transplant urine production. For any patient that's on dialysis, they should have imaging of their kidneys in 3 years, just because these patients are increased risk of renal malignancies, and BCG and urinary can be considered in the appropriate patient. Where a lot of these information for the upcoming presentation came usually from update series. The EUA itself has not published guideline recommendations. The EUA has in fact published recommendations chaired by Professor Rita, and this was most recently released in February 2023. And the American Society of Transplantation that's published consensus recommendations. So starting with our youngest patients first, like I mentioned, about 20% of these patients are going to have a urologic issue that has led them to go progress into ESRD. A lot of these are related to general anomalies of their anatomy, patients with valves, Penile syndrome, multi-system dysplasia kidney. And there's also genetic causes of ESRD as well. Alport syndrome, it's a type 4 collagen abnormality, cystinosis, bacterial, as well as pulmonary nephritis. So for pediatric patients, an abdominal ultrasound should be obtained. This allows for imaging of their kidneys, their bladder, and also understanding their post-mortem residual. And depending on the patient, a BCG or ureteral study may be necessary. The benefits of a bladder augmentation in this patient is it allows for patients that have high pressure voiding and have in turn resulted in ESRD, is we're able to create a lower pressure reservoir. And usually this can be done into native ureteral tissue, especially if there's significant hydronephrosis, hypernephrosis, or can be done with an enterocystoplasty. And the transplant ureter should go into the bladder portion of this cystoplasty or into the native ureters themselves. The KDIGO guidelines suggest that any pediatric patient that would be a candidate for unilateral or bilateral native defective prior to the transplant is one that's being dehydrated just because of significant urine loss, significant protein loss resulting in hyperalbuminemia, or it is so small that there wouldn't be space for a new transplant to occur. Next, going into andrology. So we know that men with CKD, because of their ESRD, have an increased level of prolactin and uremia. Both of these cause a hypovolemia state due to inhibition of the LH receptor. If you look at semen analysis in men with CKD, We can see decreased volume, oligocenterspermia, and then if you take testicular biopsies, which shows fertility cell atrophy as well as increased fibrosis. Medications that transplant patients will eventually be on, corticosteroids and mTOR inhibitors, may also cause iatrogenic hypogonadism, and cyclophosphamide might cause sperm DNA fragmentation. Generally, the treatment of infertility is going to be the same as it is in the general population. And with erectile dysfunction, ESRD is causing an acceleration of atherosclerosis and causing vascular disease. They looked at studies on men and PhD that had hypogonadism causing erectile dysfunction. They were successfully treated with 5 grams of testosterone. And a lot of these patients will recover after their renal transplant because their prolactin levels will normalize and their uremia will also normalize. So for a lot of these patients, we're considering a surgical approach to their erectile dysfunction. It's better to wait until they have their renal transplantation, have their kidney function recovered, and see how they progress. A lot of patients will improve. There's always a concern for infection. These patients, especially since they're immunocompromised, and there's no increased risk of infection and complications after insertions of prosthetics in patients that are on immunosuppression. Now looking at urogynecology, the most common complication is urinary tract infections in these transplant patients, and the use of a ureteral stent has always been argued to increase the risk of UTIs. But at the time of stent removal, studies have shown that only female sex was the factor associated with an increase in UTI. The prior studies that were performed, a lot of patients were on Bactrim or PGA prophylaxis. And now as times change, a lot of patients are in total mode, so they don't have that natural prophylaxis against common GI organisms. Issues with urinary tract infections is on the CT scan, acute pyelonephritis and graft injection are going to look very similar. So it's different. It's kind of difficult to determine whether it's rejection versus infection. One thing that would be a concern is asymptomatic bacteria. A lot of these patients are being frequented by the emergency room department, where they're going to have to urine collected basically any symptoms that they present. Just because they might have a positive urinalysis, it doesn't necessarily need to be treated only if it's symptomatic. It's not a risk factor for progression to UTI. And these patients are just at risk of different organisms that we normally would not be concerned about, Corynebacterium, BK virus, EB virus, CMV, human tuberculosis. And the definitions of recurrent urinary tract infection stays the same as it would with a patient without a transplant. It's asymptomatic UTI within a year. And at this point, anatomical blood functional studies could be considered, especially getting simple PVR to ensure that these patients are emptying their bladder, also getting uroflow or urodynamics. At this point, also getting transplant ultrasound or CT, successful obstruction, it's an abscess or a complex cyst, and a reflux is suspected of getting reporting system. A lot of strategies that we use for patients without transplants can also be considered for patients with transplant as well. We've also looked at studies with pelvic reconstructive surgery. Because a lot of these patients that are on USRD are not producing as much urine, a lot of urinary incontinence will be passed prior to their transplant, so that once they do get their transplant, they're now making a lot more urine. Now their incontinence is being unmasked. So you use the mesh is saving these patients, and a lot of studies have shown that it is. There's no increased risk of infection, rejection, or erosion of synthetic mesh grafts. And these patients can undergo the same antibiotic prophylaxis that other patients will be able to go. There is a concern for graft injury with retropubic prostatectomy. Just being aware of the anatomy is important. For a lot of these studies that have been studied, transvaginal hysterectomy, anterior posterior varus, urosacral ligament suspension, transoperative slings, and tension-free transvaginal tapes. Next one is stone disease. The prevalence of transplant urolithiasis is really low. It's either normal formation or donor calculi that were known or unknown. A lot of these patients will have hyperparathyroid cells right near to their ESRD. They'll also be on calcineurin inhibitors. This results in a pro-stone formation state. The presentation of these symptoms might be a little bit different just because they're transplant by demur. So you may not be experiencing some of that pain, but a lot of this will be incidental based on imaging or lab findings where they come in with renal failure, where they might just have hematuria or urosepsis. The treatment to intervene on these patients should be low, especially since it is a solitary functional kidney. Studies have suggested that trying to expulsion therapy for stones less than 4 millimeters is partially obstructing. I think there's such a low threshold to intervene on these patients, and usually with their urgent percutaneous nephrostomy tubes. followed by ureteroscopy. And this is sometimes at the time of transplantation, these donors are known as stones. So there's the ex vivo treatment of stones, where they're using a laser directly into the donor ureter to treat these stones, or they're performing pylotomies for transplanting these kidneys into these patients. Next one is avoiding dysfunction. So bladder outlet obstruction is a common, is increasing cause of ESRD in a lot of patients. The issue is that a lot of patients are not producing urine production for their symptoms to really just clear themselves, and usually this is seen after they've been transplanted, after they've had an increase in their urine production. So it's usually underappreciated how many patients have silent progression of their pH during their annual periods. With this, I think there is studies that have shown that there's a 1.2-fold increase in graft loss in men with post-transplant pH that was unrecognized at the time of transplantation. For men with the urologic cause of ESRD, for which these patients would fall into, they recommend obtaining urodynamic studies in ECG. With patients that have normal urine outputs from their non-functioning kidneys, this workup would be very similar to the general population, and medical treatment can be utilized. For patients that are going to be considered for surgery, it's recommended that these surgeries occur after transplantation if they are anuric, just because if you do a BPH outlet procedure on someone that's not making urine, they get something called dry urethral syndrome, with an increased risk of urethral strictures and bladder contracture because it comes from urine across the recently intervened site. It's usually recommended waiting about 1 to 2 months on transplantation. A lot of patients are going to have diabetes as a cause of their ESRD, and secondary to that, so that they had nephropathy from this, they're also going to have abnormal bladder function due to neuropathy as well. So if someone is diabetic, recommendations are to assess their bladder function, probably get a uroflow, urodynamics. I think this is underutilized, but it's definitely something to consider. And if patients have high storage pressures based off these uroflow studies, then definitely finding other ways to enter the bladder, where CSC or suprapubic catheter should be approached. And what the programs that have been offered is something called progressive bladder rehab, where patients would have either straight cath or suprapubic catheter, and they would practice filling their bladder and expanding it every so often, just so that their bladder is getting accustomed to the production of urine post-operatively. If a forming diversion is to be occurred, whether that be a ileal conduit, an ileal pouch, or bladder augmentation, and that's generally recommended to occur about 10 to 12 weeks prior to transplantation, just because it's occurring in the post-transplant period, these patients that are at higher risk of infection. And then lastly, urethral stricture disease. This can be idiopathic, traumatic, or can be iatrogenic in origin. And management is again going to depend on the size and length of the stricture. Similar to the dry urethral syndrome of bladder outlet obstruction, similar for these patients, it's generally recommended that it's postponed until they have urine output, because there is that risk of forming either bladder neck contractures or recurrent strictures. Historically, patients have had pancreatic transplants where they would have to do a renal segment draining to the bladder. This was a way so that they can measure the urinary amylase to see the function of the pancreatic transplant. Those enzymes themselves can also cause urethral strictures. We've actually moved away from this historically, so we should see less and less patients that have this kind of anatomical changes. Lastly, urinary incontinence. There's been case reports of the use of an AUS in just 2 male renal transplant patients with stress urinary incontinence. And essentially, the recommendations are to just be careful because the iliac fossa could contain their kidney transplants, so you want to look for nearby that or injured possible vascular anastomosis. Lastly, going to urologic oncology, this is probably where a lot of the inpatient consults are going to come from other teams that are going to ask for our recommendations, how we should manage patients with the concern for possible GU malignancy prior to them being listed for a transplant. And the key things to consider for GU malignancies is previously any active malignancy was the absolute contraindication, but the more that we know about how cancers are different, the same way medicines are different, the same way transplant medications are different, we can really adjust our recommendation based off the type of cancer that they're having, risk stratified. One thing important that we tend to use, or medical oncologists tend to use PD-1 and PD-L1 inhibitors. These are associated with significant risk of graft rejection, so they're unable to be used in patients with transplants. It also allows patients who want to avoid nephrotoxic chemotherapy. It's going to start with renal masses, just because how prevalent these are. Patients with chronic kidney disease, about 30 to 50-fold increase relative to the general population, and secondary to their existing kidney disease, rather than immunosuppression. They did studies on patients with HIV, with ESRD and without ESRD, and only found this increase of risk in patients with ESRD. So that's how they deciphered that it was not immunosuppression, but the ESRD that was responsible for their increase in renal disease. With patients with renal masses, generally speaking, we're going to be using IV contrast to help diagnose this. But the best type of contrast to use in patients for getting an MRI for working with their renal mass would be type 2 macrocystic agents, contrasted linear agents. Something that we shouldn't have to worry about, but in case we are asked about it. And again, the treatment and management is going to depend on the stage. That's going to help determine the prognosis for these patients as well. So for small renal masses, less than 4 centimeters, or even complex vasoactive forces, active surveillance is actually accepted treatment management. You do not have to remove these masses before receiving transplant, and it shouldn't delay whether a patient gets their transplant or not. For stage T1B renal masses, at this point, renal mass biopsy has a role. If it's grade 1 or 2, based on the World Health Organization ISAP nuclear grading or by Fermi grading, then these patients can proceed to transplantation, and then treatment of their mass can occur after their perioperative risks have decreased from a renal function standpoint. But if they do have a grade 3 or 4 lesion, it might make more sense to wait 1 to 2 years after treatment to ensure that they don't have any recurrences. For stage T2, T4 renal masses, these patients should undergo surveillance for 2 years after treatment before, just to ensure that they don't have a recurrence. And for patients with node-positive disease, metastatic disease, with sarcomatoid rhabdoid pathologies or collecting conventional pathologies, these patients should avoid, but these patients are not candidates, unfortunately, for solid organ transplantation. Sometimes we see these tumors occur on the allograft themselves, but that's purely a function of time and donor-related risk factors. Like I mentioned before, the immunosuppression itself doesn't increase the risk of malignancy there. Partial infection should obviously be considered just to maximize renal function that patients end up on. And usually for advanced renal masses, mTOR inhibitors are considered, and these are also used as immunosuppression for transplant patients as well. And so these are accessible first-line treatment options. Next, moving on to prostate cancer, we've looked at the standardized incidence ratio of patients with the general population and patients that have received a transplant and have found no increase in risk of prostate cancer for men with transplants on immunosuppression. So the transplant guidelines recommend the same screening criteria that we use for general population for the transplant population as well. So things to consider in these patients is because of their decreased renal function, they'll have higher levels of PSAs. So they might have an increased risk of false negative. And then also, and with liver cirrhosis, PSA levels are generally lower. And again, if a prostate MRI is performed, recommend use of type 2 gadolinium contrast. So men with low risk disease, Nuisance 6, PSA less than 10, they can receive transplantation regardless of whether they're with active surveillance or if they're treated with local therapy. For men with intermediate and high risk localized disease, at this point, nanograms are very important. If the cancer specific mortality is less than 10% over 15 years, these patients may receive transplantation. And for patients with high for intermediate risk that are on active surveillance, these men may proceed. For higher risk, it should be after localized treatment. For castrate-sensitive metastatic prostate cancer, this can be a case-by-case scenario. If they have low volume of disease, they have durable response to first-line therapy, these patients may proceed. And they've looked at abiraterone and it's shown that it's safe when it's evaluated for its drug-drug interactions with medications that these patients might be on a transplant. Following their transplant. For men with castration-resistant metastatic prostate cancer, these patients are unfortunately not candidates secondary to their prognosis.
So if they have intermediate risk, they could proceed with transplant prior to treatment of prostate cancer.
Yeah. And then for patients with prostate cancer that have been transplanted, The biggest concern, I think, is for a lot of patients, if we were to do a prostate biopsy, they have increased risk of infection. And fortunately, studies have shown that a study of 60 patients that they had very similar rates of urinary tract infections, urosepsis, and bleeding following chest biopsy. And if a patient is to be operated on after having a transplant, just understanding that there's going to be an anterior implantation of that ureter to the dome of their bladder, and usually a ipsilateral lymph node dissection is omitted for these patients. Next, moving on to urothelial carcinoma. So these patients have about a threefold increase of developing bladder cancer after renal transplant, and usually this is higher rates of muscle invasive diagnosis at the time of diagnosis. The big things here is doing any type of expiratory urography is going to be ineffective just because these patients aren't really excreting contrast in their collecting systems if their renal function is so poor. And also if they have an anuric, their bladder volume is going to be smaller, and so their ability to tolerate an cystoscopy might be lower. The guidelines recommend a screening cystoscopy with urine cytology for any patient that's had a greater than 30 pack year smoking history, if they've had prior exposure to cyclophosphamide, or if they're regular users of compact analgesics. BK virus, which is a common pathogen for these patients, also increases the risk for both hematuria and bladder cancer for these patients. And intravesical BCG, while we might be concerned about a BCG-related sepsis, the issue more here is that the immunosuppression that patients are on may reduce the efficacy of BCG in these patients. They found that there's no significant increase in risk of a disseminated BCG infection due to the immunosuppression. And like I mentioned before, pembrolizumab and also PD-L1 checkpoint inhibitors can't be used because they're increased with an associated rate of graft-related function. So for patients with low and intermediate risk non-muscle invasive bladder cancer, these patients should have a disease-free interval of 6 months prior to proceeding with transplantation. This is mainly a balance between the patient's cancer trajectory and minimizing delays to transplantation. For patients with a high-risk non-muscle invasive bladder cancer, their risk of recurrence is much higher. So they recommend a two-year disease-free interval before proceeding to a solid organ transplantation. And if patients are already on a BCG course, it's probably recommended that they complete their 3-year course before they proceed to transplantation. For patients with muscle invasive bladder cancer, the recommendations are they can be treated with radical cystectomy. If they are going to get neoadjuvant chemotherapy, it should be dose reduced and coordinated with their hemodialysis sessions. And ileal conduit is obviously preferred for these patients with GFR less than 40. And again, if these patients are treated and have disease-free interval of 2 years, then they too can undergo a solid organ transplantation. The numbers and the data is still not there for trimodal therapy. Might be something interesting to take a look at. We're able to generate the number of patients. Moving into testicular cancer, a lot of the serum tumor markers might be falsely elevated in the setting of these diseases. For stage 1 seminoma, if the patient receives any type of antigen therapy, or if they don't have any significant risk factors, then they can proceed to sort of solid organ transplantation just based on the urgency of it. If it's less urgent, then they can monitor or surveil for 2 years before transplantation. For stage 2 to 3 seminoma, if it's Goodrich disease and completely treated, then they can proceed to transplantation without delay. If it's intermediate risk, then it's on a case-by-case scenario, generally waiting 2 years for solid organ transplantation. And for non-seminomatous germ cell tumors, for Goodrich disease, you can proceed for intermediate risk 2 years, and for poor risk disease, it's going to be a case-by-case situation. And lastly, for penile cancer, with all these human papillomavirus associated cancers, about 10 to 20-fold increase in the incidence of penile cancers. In patients with local disease that was treated, they recommend a multidisciplinary setting review prior to transplantation. Just secondary, just the low numbers of patients with penile cancer that are being transplanted. For patients with nodal positive disease, again, they can be considered, but with caution. So in summary, for these malignancies, renal cell carcinoma is likely related to their renal dysfunction rather than immunosuppression. And everything's dependent on the staging. For prostate cancer, we know that's not affected by immunosuppression, so they can proceed mainly if their cancer-specific mortality is adjusted to be less than 10% over 15 years. We know for bladder cancer, there's a threefold increase post-transplantation, so stratification of non-muscle invasive bladder cancer for at least 2 years post-treatment for muscle invasive bladder cancer. And penile testicular cancers are rare. This kind of depends on staging. Lastly, we'll talk about graft hydronephrosis. It's one of the most common reasons will be consulted in the post-transplant setting. Usually, the uroneal cystotomy is performed in a modified liturgical and anastomotic technique over double J stent. A mild degree of transplant hydronephrosis is considered within normal limits, and reflux is common within these patients and can be evaluated with cystogram and BCUG. But it's important to make a prompt diagnosis because this is a solitary functional kidney and it's dependent on nephron preservation. So, like my colleague, she likes to ask what the experts have to say about graft hydronephrosis. So I asked Dr. Singh what he would say about hydronephrosis, and what he would say is just because you see hydronephrosis on a CT scan or imaging doesn't mean it always equals obstruction. It could be reflux. So it's important to determine whether the hydrogen is related to reflux or obstruction. Then I asked Dr. Ken what if it was obstruction, what he would say, and he would say that the degree of hydronephrosis does not correlate to the degree of obstruction. Then I'd have Dr. Colbert, and he would teach me about the surgical techniques of urethral reimplantation. But most importantly, he would say it's important to take care of the patient. And lastly, if there is any time that we need to fix a ureter, I'll call Dr. Sterling. But again, ureteral strictures are one of the most common reported ureteral complications following renal transplantation. The incidence of requiring reintervention is about 0.8 to 3.6%. So within the first week, it's probably a technique-related technique for a ureteral kink. Otherwise, downward probably related to either disruption of the ureteral blood supply or rejection. And then robotic techniques have been described for the extravesical reimplantation of these patients, but there's a 40% in conversion rate that's moving forward to be done there. Otherwise, for less than we have strictures, and this topic of treatments are still reasonable. Just want to acknowledge Dr. Paul again, who was very important in doing this kind of feedback. He's a great individual who had a chance to work with them. Moving forward with well. Questions.
Patient has let's say a 5 centimeter renal mass being considered for transplantation. You're going to take them for, you had suggested partial nephrectomy?
Renal mass biopsy
Yeah.
for these patients and just determining the nuclear grading.
Yeah.
If it's grade 1 or 2, then you can have them get their transplant first, and then once their perioperative risks have decreased, then do the nephrectomy. But if it's something with a higher risk of recurrence, then treating it first, surveilling that, going for transplant.
But if you're choosing partial nephrectomy versus radical nephrectomy, is there any reason that you would pursue partial nephrectomy in someone who is in end-stage renal disease considering transplant?
I would do a radical in those patients. I think the partial was for someone with a cell for a graft tumor.
Regarding the kidney cancer for transplant patients, it seems pretty clear that prostate cancer, the incidence is equal to normal patients, and urothelial cancer is much higher. Did you came across during your research on actually the data of kidney cancer death, like the SIR? Because I don't remember. There is a lot of recommendation on kidney cancer, but is the incidence of death, the SIR, is actually higher?
So they just said it was 7 to 8, but I think it's hard to differentiate. Or it's just for risk. They have other risk factors that are contributing to their mortality versus cancer-specific mortality.
Quick question on the localized prostate cancer in these patients. You said the radiation data shows that there's no graft malfunction or decreased risk.
They show that radiation is safe. They show that prostatectomy is also safe in patients, just in the hands of experience. Just knowing more so where the anatomy is so that transplant can be ensuring that the ureter is not injured during the dissection or during these rectus. I looked to see if rectus sparing prostatectomy might be more feasible for more appropriate for the patient. But the data shows that either way, just doing a standardized approach versus a rectus sparing very similar. That one's good.
Kidney transplant provided now. In some cases, and I think they're intraperitoneal.
They are. So they're intraperitoneal there. So you might encounter during I think it might make sense for those patients to just notify our transplant surgeons ahead of time. Just for it's not required application.
Back Martin, we do a sling on transplant. I make me nervous. I never really thought of that.
I have not. I've cared for someone who had a transoperatory afterward and did get recurrent UTIs. Yeah, she had a liver kidney transplant. But I think a retropubic case would be fine because you really need to stay right in synthesis. That's sort of what I always say 100 times.
You still do retropubic as opposed to TBC?
The two people who trained me in slings, Foster and Roz, we were always top down. So I think you can hug the symphysis pretty easily in that approach. Whereas I think having not too much experience in the bottom up, you may be a little bit more anxiety proven to go that way, unless you're really hugging the bone. I think Leslie would have to. Yeah, the retropubic TPTOs are great, except that they don't treat ISD cases. So I think it's again a case by case situation. That would be intrinsic sphincter deficiency. So that procedure was designed for hypermobility, and it does work very well. But
I have a consult coming up. That's why I asked the question. You may see a case soon. All right, thank you.
Great.